And thanks to all of you for coming. I really appreciate Pearson giving me this chance to talk about my work. I'm a longtime fan of the MMPI instruments, got my PhD at the University of Minnesota. And then really my particular angle on things that you may have heard about is how to take these wonderful tests like the MMPI-3 and use them to help people directly, not just in diagnosis and treatment planning, but how to make an impact on the person's life. So my plan today is to tell you a little bit about therapeutic assessment at the beginning, for those of you who aren't familiar with it. Then I have an actual case that I'm going to show you. So I recently videotaped a client who took the MMPI-3 and was very generous in letting you all know about the work that I did with her. So I'll be showing you videos. Unfortunately, there's a lot to go through, so I'm not going to have time to stop along the way and take your comments and questions. But if I'm really good, we'll have some time at the end. And if not, feel free to email me at this email address that you see here if you have questions afterwards. So thank you again for coming. So first of all, for those of you who don't know, what is therapeutic assessment? It's a semi-structured form of collaborative psychological assessment based on the work of people like Constance Fisher, Leonard Handler, Caroline Purvis, and others. And the main idea is that psychological testing is not only used for diagnosis and treatment planning, and even with TA, you can perform these functions. But it's the centerpiece of a brief, empirically validated therapeutic intervention. Clients are enlisted in as collaborators in all phases of the assessment. They help us set the goals of the assessment. They help us interpret the test results. They comment on our feedback and let us know whether we have understood things correctly. They review any written reports, and they decide who is going to receive copies of these. So many TAs are as short as 2 or 3 sessions. We call this ultra brief TA, and are useful in settings with high service demands. So if you have a lot of people on your waiting list and you want to give them something, and then you might consider doing brief TAs and brief TAs with the MMPI-3. Just a quick summary of the research. There are now over 35 published studies of therapeutic assessment and its close cousin, collaborative assessment. Most of the articles may be downloaded from the website of the Therapeutic Assessment Institute under our resources tab. And you'll see if you look at these, they involve a variety of clients and clinical problems and settings and research designs, outpatient, inpatient, people with depression, people with chronic pain, people with PTSD, you name it. Most involve very brief TA, 2 to 4 sessions, and many of these use the MMPI-2 or MMPI-2-RF. Not always, but many of them do. There are 3 meta-analyses that have been done over the last period of time that have documented 3 main types of effects of collaborative therapeutic assessment. This is what mainly we achieve. There's often a reduction in clients' symptomatology, and the effect sizes range in the small range from 0.19 to 0.37. Clients who are more symptomatic, like clients with psychoses or severe personality disorders, we see less change in symptomatology, but effects in 2 other areas. There's increased satisfaction with ongoing treatment, greater alliance with treatment professionals, and higher motivation for future treatment. And these effect sizes tend to be large, moderate to large. And so if you have clients who tend to drop out or not follow through or not really be excited about treatment, a brief therapeutic assessment with the MMPI-3 can get them engaged and ready to work. And we also find less shame and higher self-esteem with effect sizes in the moderate range. And these are the 3 meta-analyses. The last slide, which you can get if you get the slides, has the exact references for the articles. So now, it might be interesting to know our current ideas about why therapeutic assessment achieves the effects. And our best understanding is that psychological assessment can produce rapid and surprising changes by helping people alter their narrative identity. What is their narrative identity? It's the internalized, evolving story that each person crafts to provide his or herself with a sense of purpose and unity. So basically, the idea is all of us construct these stories about ourselves based on our life experiences over the years, and these help us sort of make sense of the world every day. But many of us have stories about ourselves that we developed long ago under circumstances where those stories were adaptive, but now they're no longer adaptive. So maybe you grew up in a situation where you were really emotionally neglected and your parents paid very little attention to you. And a story you might have developed about yourself is, I'm not very important or worthy. That helped you adapt to your family at that time, but it can get in your way in adulthood in all kinds of ways. Now, self-narratives are typically very difficult to alter because of what social psychologists call the self-verification motive. If you know any cognitive psychology, you know about this. We tend to screen in information that fits with our existing stories about ourselves and screen out information that doesn't fit. Try paying a compliment to a person with low self-esteem, and you'll see exactly what I mean here. And we even select social situations where our narratives are likely to get validated and confirmed, and we avoid social situations where people will give us discrepant information. Psychiatric client stories may be particularly resistant to change because they often protect from shame and disintegration. And, think of psychiatric stories, clients who have, for example, narcissistic characteristics and very distorted and grandiose views of themselves that are not really accurate. They're not going to take in new information because if they took it in, then probably they would plummet into the underlying shame that they're defending against. So now, the basic idea of collaborative assessment and therapeutic assessment is clients are most likely to make changes in their story if they're actively involved in examining and co-editing the story. So they have to co-edit their own work of art in order for us to be able to change it. And so involving the client as a collaborator helps protect against their defenses against the news stories. And they're not likely to disintegrate and they're not likely to fall into shame if they're having input all along the way about how to revise their story. And then we have these wonderful psychological tests like the MMPI-3 that are really empathy magnifiers that we can use. We use our test to get in our client's shoes, the name of one of my books. And this tells us, first of all, what the existing story is, where it might be open to change, what information the client can take in without sort of going into some crisis state where they defend against the information, and what information is likely to be too hard for them to take in. And if you're really good at interpreting your tests, you're able to think about all these things. Now, the benefits of using the MMPI 3 are really a lot. First of all, it has established validity for a wide array of clinical problems, recently renormed, as you know. It's easy to explain to clients how the test is relevant to their concerns and to explain the science behind the test scores. You can tell people, well, the way we came up with this depression scale is, and tell them a little bit about it. Very little clinician time required. Most clients find it very easy to complete. Most of the clients that I see in outpatient practice can complete it within 45 minutes to an hour. And this is another reason to use the latest form of the test. The MMPI-3 has very homogeneous scales that are easy to explain to client. For those of you who liked the MMPI-2, which I used for many years also, you'll know it was very hard sometimes to know what high scores and low scores meant because the scales were very heterogeneous. And so they could mean one of 5 or 6 different things. If you were good at the MMPI-2, you could use other scales to kind of figure out, do a little mini factor analysis in your head to, oh, this is what this means. But in the MMPI-3, the scales are very homogeneous and uniform. They mean what they mean. And because they're so homogeneous, it's very easy to interpret low scores as well as high scores. And this turns out to be very useful in understanding people's problems and living. So the other thing that's been true in the MMPI instruments for a while, the profile graphs use uniform t-scores with known percentile ranks. So we know a t-score of 65 is the 92nd percentile, and we know that a t-score of 80 is the 99th percentile, and et cetera. These are all, you can print out the table and use these when giving feedback to clients. And this is very useful piece of information for clients to sort of be able to gauge where they are relative to other people. I work a lot in Japan, and the Japanese have a saying, the fish doesn't know it's wet. And, we're not aware, because we just know ourselves, how depressed we are compared to other people. And these MMPI-3 percentile ranks are very useful in giving feedback. Low scores, as I mentioned, can be very useful, and they can show us areas where clients are very blocked and don't have normal access um, to emotions. Clients on the Psi-5 aggressiveness scale who are way, way low, those clients don't have the ability to harness aggression and assertiveness to protect themselves and achieve their goals. And you can use that low score to talk to them about it and show them they're way below where most people are. Now, therapeutic assessment is a flexible process. In the full model, there are 6 sessions. And the initial session I'm going to talk about today, the client takes the MMPI-3. There's an optional third step where you can do either an extended inquiry or an assessment intervention. And the client I'm going to show you, I did an extended inquiry, and I'll tell you about that. Then step 4 is what used to be called feedback sessions. I don't like the word feedback session because it has this idea of the guy with all the answers in the white coat who's giving you the real truth about yourself. And it really should be more of a dialogue, going back and forth, sharing a result, asking for the client's input. Does that seem right? Can they think of an example? Hopefully you'll be able to see that in my videotape today. Then in therapeutic assessment, we often provide written feedback to the client in the form of a letter. And we often will do follow-up sessions a couple months afterwards. And so this is the full model. But the assessment that you're going to see today, for example, is just 3 of these steps. The initial session, client took the MMPI, then I did an extended inquiry, and I did a summary discussion session and a written feedback. So actually 4 steps. So. Now, let me tell you about our initial sessions. Okay. The main goal is to engage the client as a collaborator and give them a sense that we really need their input to conduct the assessment. And we want them to feel welcomed and safe and accepted. We put a lot of attention to alliance building. And one of the ways we build alliance is by inviting clients to frame individualized questions that we'll use to sort of structure the assessment. And so you'll see me do this in the first session where, and actually I had talked to the client on the phone, and she gave me a question immediately on the phone. There's an art to developing these individual assessment questions that I can't go into depth here today, but we've written about it in our most recent books, et cetera. And then once you have a question, you collect background information about the question. So if the client says, how depressed am I compared to other people? You say, oh, great question. And when did your depression begin? And people use the word in lots of ways. How does it show up for you? And what's your current theory about how depressed you are and why you're depressed? And so you get a lot of information just by querying the assessment question. You agree upon the contract for the assessment, how much it's going to cost, how many sessions, what the client can expect, who the results will be shared with, and then you schedule the next assessment session. Now, why do we collect these assessment questions? And they have a lot of purposes that I want to go over. They lower clients' anxiety by defining the contract for the assessment. So people know what basically we're using the test. And if there's a referring professional or a judge or a hospital, then we try to get questions from them and share those with the client. Dr. Smith has asked me blank, what would you like to know about yourself? So this engages clients as active participants. And we even have some research showing that they produce more open and honest MMPI profiles if they have been asked to pose assessment questions, rather than if you just do a traditional initial interview for an assessment. Now, the questions are also assessment instruments in themselves. They give you an idea already about clients' current self-schemas and their narrative identities. And they also show where clients' stories are open to change. If a client says, I know that I'm way too angry a lot of the time, and I want to know what I can do to change that, then you have an open door to talk to the client about all kinds of things from the MMPI. And this enlists clients' curiosity. And curiosity is a very good state to be in if you want to start making changes in your life. I remember years ago being in therapy and I was, very upset about something. And the therapist said, great, Steve, oh, those feelings are very hard. Let's climb on the observation deck over that event and let's see if we can look at it and try to figure some things out about it. And my state changed immediately. And these questions are the open doors we use to discuss difficult information later in the assessment. Our MMPI-3 is good. It'll give us information that's not coherent with clients' current self-narratives. And it's very useful to be able to connect that information to a question if we want to help our clients. Now, let me tell you about the client we're going to be working with. This is actually, I think it's, yes, 29-year-old, excuse me, I think that's a typo. Maybe it's 39, woman in individual psychotherapy with a colleague of mine here at the Center for Therapeutic Assessment, Kate. They've been working together for over 2 years. The therapy is going really well. Sometimes we do therapeutic assessments to assist in psychotherapies that are not going well. And sometimes we do them at the beginning to help people get ready for therapy. But this therapy is going pretty well. But Kate felt that the therapeutic assessment would help deepen the therapeutic process and maybe help speed it up. And we have some evidence that if you do assessments mid-therapy, the rate of change after the assessment changes and increases. The client knew from the beginning that I wanted to videotape the assessment and show the tapes at this webinar. She was very comfortable with that. We discussed it in great detail. And when I talked with her on the phone, she was very pleasant, very easy to connect with. I told her that I wanted her to think about what questions she might want to have answered from the assessment. And she said, okay, she would. I said, any come to mind immediately? And she said, yes, where does the belief come from that I'm not good enough? And I said, oh, great question. Keep thinking of other ones. And then when we meet, we'll write them down and we'll use our testing to help answer those questions. A little background about Ms. J. She's a struggling actor and film director, currently working as a waitress to support herself. She defines herself as queer. She's not currently in a relationship and had some recent difficult relationships that she's still recovering from. She's the oldest of two. Her brother is 5 years younger. Her father traveled a lot for work, and the mother had a severe drug abuse problem. And at times she would just abandon the kids in the house, go off, and they would have no one to take care of them. Other times she was present, but in sort of a drug stupor and would be unconscious for long periods of time. The father was kind of in denial of the mother's addiction, but eventually divorced. And the father's secretary helped to do some parenting of her and her brother, but she was a lot of the time with her mother, who was not taking good care of her. She is currently in regular contact with both her parents and with her brother. And that is both a good thing, I think, but I think also has some challenges that I'll tell you about later or talk to her about. You'll see. Again, I'm sorry I can't stop at this point to take your comments, but I'm imagining, maybe I'm wrong, some reactions some of you might have to that, which are what an incredibly eloquent and resourceful and amazing client, right? So Steve Finn chose the easy one to show. So, and I'm aware many of you, and I also sometimes work with clients who are not so fluent, clearly haven't done as much work on themselves as she has done. I mean, she's just delightful in her ability to discuss these things. But another reason I like this case is, can we help a person who's done all that work on themselves with a brief assessment? Can we still teach them anything about themselves? And so let's hold that in mind as we go through the rest of the assessment. And then, because I think it's fair, in a way, this is almost a harder question to help. So, yeah, so okay. Now, let me go back to my slides. Um, okay. These are the slides that Ms. J and I developed. We talked more about these rejections and especially if she gets a professional rejection, she's an actor and film director, and she will sometimes get very far in a audition process and then be rejected. And then it kind of paralyzes her for a while, and she finds it very hard to go to other auditions or keep putting herself out there. And so the question we came up with is, how can I mitigate the collapse that happens when I feel I've been rejected? Then I asked her what else she might like to explore. We came up with two other questions. Why do I think I'll be a burden if I ask for help? How do I change this? That really came out of our discussion at the beginning. And, you know, she talked about, it's very difficult for her to reach out for help when she's in one of these places. And she really finds it very difficult. And interestingly, she didn't seem to have a lot of insight already about where that might have come from, but she also wanted to know how to change it. Then we got talking about relationships and friendships a little bit. And she told me about a intimate relationship that she had had with a woman that had ended, I think 3-4 years ago at this point. Very abruptly, the woman left her and had an affair with another person and went off. And she finds herself still unfinished with that relationship and upset about it, thinking about the woman, wishing she could be back with her. And so we came up with this question: what will help me move through my grief about the relationship with this woman? And so those are the questions that I accepted. Okay. So I bet you can't wait to see the MMPI. She took the MMPI. I sent her a link via email, and she completed it at home by herself. This isn't a forensic situation where I have to monitor the client doing it, so I felt comfortable with her doing it at home. And I got notified of the results, and I got the profile. And these are the results of the MMPI. I want to thank Dr. Yossi Ben Porath, who I decided I would consult with him about the profile. So he and I talked about it together, and it was very helpful. Even though I'm pretty good with the MMPI-3 myself, he's, of course, the master. So these are the validity scales, and you can see there are really no problems with random responding or not understanding the items. She hasn't endorsed a lot of extreme distressed or disturbed items. There's a little bit of somatic complaints coming through. I'm assuming you all know how to read this. 50 is the average score in the normative control group. I've done the comparison group I chose was women clients in outpatient therapy. outpatient private practice, and that's these dotted lines. These are her scores and the lines. And this is the bar one standard deviation above and below the comparison group that I chose. L and K are extremely low, way below what most people do. And I like the phrase Yossi said when he saw these. He said, well, she didn't have even one good thing to say about herself during the test, did she? So, and this really fits with the problem she's been describing. Here are the higher order scales. You can see most of our problems coming from internalizing painful affect states. Interesting in a slight elevation in the thinking area, and not really a person who acts out. And highest possible score on demoralization. This woman is feeling knocked down by life, hopeless, not able to sort of pick herself up and get going. And she's at the 99th percentile, the T-score of 80. What a very, very painful place to be. And we know that people with high demoralization scales, it affects them in all kinds of areas. They have suicidal ideation. So I'll be looking at that later in the test as we go along. Little bit of somatic problems. We saw that in the validity scales too. Uh, Average on these scales, and we have an RC6 elevation. And remember, RC6 compared to the scale 6 on the MMPI-2 is really a lot of, frankly, paranoid items. And so that's what's causing our little elevation on thought disorder over here. And I'm very curious about it. So, and RC8 has some overlap with this. So I suspect we've got a little bit of suspicious paranoid thinking. RC9 elevated. And we'll investigate that some more too. These are the lower order scales. So a little bit of elevation on eating concerns, which I was curious it was about. Highest possible score on self-doubt. This is the shame scale on the MMPI, in my opinion. People with scores like this, again at the 98th percentile, are full of shame about themselves, have a deep narrative identity of being defective, not being good enough. It's a core part of their narrative identity. She's feeling not very efficacious in life. She has been struggling a lot, I know, in her career. She worries. There's some compulsive tendencies, anxiety-related experiences. When Yossi and I talked about the profile, he said that he wondered about some PTSD. And partly you'll see in some of the item content, she also endorsed some dissociative experiences, which I ended up talking to her about in the second session. And behavioral restricting fears. So she's very fearful of putting herself out there. She restricts her life, expects rejection, and it keeps her life much smaller than probably she would like it to be. Family problems, no surprise. She wasn't a bad girl who did a lot of acting out. She doesn't abuse substances, and a little bit of impulsivity, which I was curious about, talking to her about. And just like our RC6 scale, she's very high on cynicism. And again, I started to think about some of the experiences she told me about when auditioning and some of these past relationships that have turned out badly recently, and wondered if there's some blocked anger about those things. I think cynicism is often a person who's become bitter and changed their view on the world because they haven't had enough support to explore the anger about the experiences that have happened to them in the past. No over self-importance, not a dominant person. She isn't endorsing a lot of disaffiliativeness, so she needs people to be happy. She would not be good with the life of a hermit. Um, she's not as connected to people, the social avoidance, as probably would be good for her sociable temperament. And she has social anxiety and shyness. So an introverted person, a shy person, but a person who needs people. What a difficult combination. The Psi-5 scales. I was surprised that her aggressiveness scale wasn't lower, but it wasn't. So apparently she can apparently harness assertiveness. And the psychoticism, no surprise, because we saw the RC6 and RC8 elevations. We'll learn more about that. Disconstraint. She's neither super constrained or super disconstrained. Some negative emotional states that we saw before. And introversion, a little bit elevated. So now, a very useful thing that you can do on the MMPI is when you are selecting your report to be printed, you can select different levels that you would like to have the items printed out. And for example, you can select to have all the items on a scale printed out if you want. And um, that you will get lists of items, and I can't show them to you because we're protecting our security of our items and they won't be on your slides. But I just want you to know she did endorse one suicidal item. I've thought about how I might kill myself. The anxiety related experiences, my anxiety gets out of control. I often think about something bad that happened to me. I panic easily. I'm easily started. Painful memories of a past event are running through my mind. I relive bad experiences. You can see the PTSD element in some of these things. And then the RC6 items come out here and the ideas of persecution. I feel that I've often been punished without cause. Some people will go out of their way to annoy me. There are persons who are trying to steal my thoughts and ideas. There are people trying to keep me from getting ahead. I'm sure I'm being talked about. People say insulting and vulgar things about me. People are against me for no good reason. And some people will be pleased if I fail. So very useful to have these items, and I'll tell you quickly what I decided to do with them, which is I also have the self-doubt items, very useful for talking to her about them, and inefficacy. So yeah, I got the items on all the scales printed out and went through and looked at them when I was looking at the protocol. Now, in step 3 of therapeutic assessment, you have another session with the client. This is optional. You can go right to giving feedback. But we find it very useful to do either an extended inquiry where we say to the client, I want to talk with you about some of the items that you endorsed and just understand them better. Or you can do another thing that in therapeutic assessment is called an assessment intervention. I'm not going to try to go into that, but you can read about it in all our therapeutic assessment publications. So I decided to do an extended inquiry with Ms. J. And the goals are to build alliance and epistemic trust, to get in the client's shoes better, use our test as an empathy magnifier by understanding what she had in mind when she answered some of these MMPI 3 items, and to clarify the meanings of these items. The items are pretty clear, but people sometimes have their own unique take on them. That's part of why the test works, but it also is helpful to know. And it opens up discussion of topics that might otherwise not have come up. And so, for example, I asked her about the eating items, those 2 eating items, and found out that she struggles a little bit with binging. She used to be much worse, but it's not anymore. And it's an opportunity to help the client feel seen and understood. I don't have time today to show you the question, but I will tell you what I learned about those paranoid items. Um, I got empathy for the life of someone who's been in the acting profession and artistic profession for a long time. And she told me about how people will sabotage other people at auditions and sort of say bad things, and that people are really wishing you ill. And by inquiring those items, it didn't seem to me like she had any paranoid psychotic thinking. The old saying came to mind, just because you're paranoid doesn't mean they're not out to get you. And I really learned that that was what had made her endorse a lot of those items. And she doesn't think she can read other people's minds. She doesn't she did endorse that item too, about sometimes I can read other people's minds. And I think it's her natural sensitivity and her ability as an actor to read people. So it settled me down, helped me understand that RC6 elevation and RC8 elevation. And that helped me as I prepared for the feedback session. So let me move towards that. So and this is how to do an extended inquiry. I'll leave that for you to read on your own. So the step 4 summary discussion session, I usually spend, time preparing it and thinking very carefully about what I'm going to say to the client. And the goals of this session in therapeutic assessment are to lay out the new coherent, more compassionate, more accurate story for the client. We're trying to change their narrative identity using our test as evidence and our authority as psychologists and our empathy for the client to get them to think about themselves in a new way. We want to answer the client's questions for the assessment. That was the deal when we started the assessment. And we want this to not be somebody with a white coat on reading the MMPI report to the client and saying, this is the truth with a capital T. We want to engage the client in corroborating and modifying the test interpretations as we go along. Because first of all, these are just statistical estimations. We may not have it exact right. But also, this is the way we get the client to weave with us the new story. The MMPI says this. What do you think? Is that right? Well, almost, but it's a little bit different. Oh, tell me. Oh, okay, great. Now I understand a little bit better. And so they're co-editing the story. We want to avoid overwhelming the client or triggering major defensive reactions. I'll tell you how I approach that. And as you give people this information, it really opens up grief processes and all kinds of emotions for people. And people will cry or get angry and we're trying to make room for that and deal with those emotional events therapeutically. Again, to go slow, go along, see how the client's responding, make room to sit with the emotions that are coming up. If the client can't tolerate the emotions that are coming up from the new story, they'll reject the new story because it's too difficult for them. And so the emotional support and alliance we built in the first and second sessions are going to be very important here. And we want the client to feel respected, understood, and valued. I want to talk to a client the way I would want someone to talk to me about these MMPI 3 scores. So I think I keep saying MMPI 2, but MMPI 3 is all I'm using now. So now, what does the MMPI 3 tell us about Ms. G's major issues? I think it suggests that her sensitivity to rejection is part of a general low self-esteem, shame, and self-doubt at the core of her personality organization, most likely related to childhood neglect and trauma. You may know that emotional neglect in childhood leads to low self-esteem and shame because the child basically concludes that they're not worthy. And it's not even thought about in a word. You just develop a sense of yourself as not worthy. You don't see sparkle in your parents' eyes when you come in because your mother's in a drug episode. And it gradually gets internalized into a sense of self as being worthless. And her sensitive temperament probably made her more vulnerable. And she may overperceive rejection now or inadvertently send messages that she does not need others. So I think that RC6 guardedness still has some implications in her cynicism about people. So this was my case conceptualization. With this, I thought I could also answer the 3 questions about why she was so sensitive to rejection, why she had a hard time reaching out for help, and really what was making it difficult for her to recover from this old relationship. I really felt like she hadn't processed the anger enough about this relationship when we talked about it. Still was idealizing this person who really kind of treated her wrong, and that would be important for her to do. And that she had learned not to do that growing up. You don't get angry at a drug addicted mother, then you get even less. So now, in TA, there's a concept that really helps us know how to give feedback, and it's something we talk about as levels of information. Once we have the primary case conceptualization, what of the assessment information maps onto how the client already sees themselves? Your questions and your discussions about questions will help you do this. And we try to especially identify information that would be too threatening because it's too discrepant from how the client already thinks about themselves, or it might elicit too much shame. And we divide our information in our mind when looking at the MMPI into level 1 information, findings that the client's already going to easily grab onto, and it fits very well with how they perceive themselves. Level 2 findings that are going to be a little more discrepant from how the client already sees themselves. These are often the research correlates to our MMPI scales rather than the content of the scales. If the level 2 information, if you tell this to a client, they'll normally say, I never thought about myself quite that way before, but I can see how what you're saying fits. And then we try to identify level 3 information, findings that are so novel or discrepant from the client's usual ways of thinking about themselves that the client will either get defended or they'll reject the item. And we want to know this before we go in. And if you sit and look at your MMPI scales and think about the questions and think about the discussions you've had, you often can parse out what you think is going to be level 1, 2, or 3. This is what I thought might be the levels of information for Ms. J. I thought her general level of psychological distress might be level 1. Her low self-esteem and self-doubt, I thought she probably was very aware of, would not be surprised by the social anxiety. Level 1, maybe 2 would be that she's a trauma survivor. I don't know if she had laid that word on herself yet, and that she currently is still struggling because of these adverse childhood experiences she had. I think she's recovering, but I think she's still right in the middle of recovering, and there's more work to do. Level 2, I thought it might be difficult for her to grasp. It's amazing she's doing all she's doing and trying to succeed in a profession where rejection is common. This is a hard profession to be putting yourself out in. And I thought level 3 might be that she needed more support for grief about what had happened to her, both in her childhood and in these past relationships. And that doing that would help her reconstruct a narrative of herself as more valuable. And I thought it might be particularly hard for her to get in touch with anger at her mother, especially because she has a relationship and her mother's sober now. That can be really tough for people. Those are what I had in mind as I approached talking to her about the summary discussion. So the most important principles of summary discussions in therapeutic assessment: order the findings in terms of their level of congruence, 1, 2, 3. You don't have to talk about the MMPI scales in the order they are on the sheet. You can flip back and forth. You can reorder the client's questions when answering them so that you start with a question where there's more level 1 information and save other questions for later. Don't make this a monologue, dialogue. Say something you think from the test. Ask if the finding fits. Ask for examples from real life. Some compliant clients will just agree a lot. So then when you ask them for an example, you find out they didn't really understand. And if the client says, no, I don't think that's quite right, ask them to modify it. And never argue about a finding. First of all, you might not be right. The MMPI is not perfect. Or the client is not ready to hear it. And it'll maybe come around later when the client is more receptive. All right, the next step of therapeutic assessment is we write a letter to clients reminding them of what the contents of the summary discussion session, and we send it to them. It's written in second person to the client. I'll just show you we address the client directly, make mention of the client's contributions to understanding the MMPI scores, avoid jargon, explain any scales referred to. But don't give too much information. These should be pretty short and sweet. Here's an example of my section of the letter from Ms. P. How can I mitigate the collapse that happens when I feel I've been rejected? As we've discussed, you have the highest possible score on the self-doubt scale, the MMPI-3, documenting what you already know. You often struggle with incredibly painful feelings of worthlessness, shame, and inferiority, and can be your own worst critic. I believe these feelings are connected to traumatic experience of aloneness when you were a child and that they were adaptive at the time. You blamed yourself rather than parents to protect your relationship with them and help keep them regulated. You are still recovering from this early relational trauma and are finding ways to help yourself when these early painful feelings get triggered. I believe talking more in therapy with Kate about your childhood will help a lot, especially if you can let yourself be mad about what happened. This doesn't mean you have to express anger to your parents to heal, but you do need a place to process the grief about what happened to you. If you fall in the shame pit after a rejection, and then I just repeat the things. So this is just an example of one. I know in this case, I didn't schedule a follow-up session, but I made it clear to Ms. J that I'm available if she wants one. And I met with Kate to go over the MMPI-3 results and talk about the therapy. And I have some forms that I give clients at the end of an assessment to ask them to give me feedback about the assessment. One is a standardized rating form. By the way, any of you can use it, that where clients rate different aspects of the assessment, and we have norms on that, and it's based on research that we've done. But another is just open-ended questions, and this is what she wrote on the open-ended question form. I found this experience to be extraordinarily impactful, helpful, and stabilizing. I've never experienced something that allowed me to feel so seen in such a short period of time, not only with immense compassion, but with real-time tools that make me feel I have a plan of action. Something about the short-term nature of only 3 sessions also allowed me to open up, as there wasn't time for holding back. It felt safe to dive straight to the deep end, and doing so yielded the most honest feedback for me. It felt so good to take my mask off and truly allow myself to be witnessed. An unforgettable experience, truly. This, to me, is an affirmation of brief therapy and how powerful it can be sometimes, because the compact format allows clients to really go deep and accomplish a lot that they might not in a longer therapy. Thank you very much. We have, I guess, about 6, 7 minutes for me to deal with some of your questions or comments. Ben, hopefully you've been able to select some of those and you can share them with me. So
I have, yes. First of all, thank you so much for the wonderful presentation and case study. We're getting a lot of positive feedback about both. I do have some questions coming in here, and I just want to let anyone know they can continue to add them at the form
great,
at the end. And
great.
Dr.
Let's see how
Finn.
many we can handle.
All right. So first, we're going to start off with some client-specific ones. Were there any co-occurring medical or cognitive conditions in her history? And they're asking because of the RC1 and THD scores.
There weren't. No, and the RC1 turned out to be some stomach aches and headaches in stressful situations. So
Perfect. Her RC9 was at 67.
yep.
Could there be a part of her that feels a bit of grandiosity, wanting to be seen, that, covered underneath some of the feelings of insecurity she had?
Seems possible. I think you probably have to have a little grandiosity to be in that profession, don't you think? But actually, and you may have noticed there was an elevation on impulsivity too. When I got with her, talk about it. First of all, she keeps herself incredibly busy all the time. I think that was part of the RC9. And she really barely has 5 minutes to sit down between the various things she's doing. And the other thing is sometimes she can just be a little bit impulsive. And we talked about that. And I think that's an aspect of her character that she'll have to keep an eye on too. And it came into play with the eating, for example. It was connected with the eating problems. So.
Excellent. Thank you so much. All right, next one. How would you tease the difference between a trauma response and faulty personality structure dysfunction? For example, your client described hyper vigilance, excuse me, with a flair of projection and critical judgment.
Yeah, well, you know, we could talk about this for hours, I think. So, um, yeah. I don't think this client would qualify for having a personality disorder based on the MMPI, and yes, he thought so also. He agreed with me. And, you know, given the history, and, you know, I only got a piece of the history, but just the few events I heard, it was pretty clear to me. And the MMPI had the indications of trauma, the suggestions of trauma too. So my best case conceptualization was this is a woman probably with some temperamental sensitivity and got exposed to some very hard events, and she had personality adaptations to it, which are causing difficulties now. So that's the best I can do. Sorry.
No, that's an excellent answer. So next one, do you typically decide ahead of time when you'll do a brief or a more traditional length therapeutic assessment, and how or when do you decide this?
It's based on all kinds of things. Um, Sometimes my time, I'm only available to do brief ones because I'm traveling and teaching or something. Sometimes it's based on clients' resources. So people can only pay a little bit. And so, and I don't do as many nowadays, but for years I did a large number of just 2-session MMPI therapeutic assessments that were very impactful, and therapists would refer them to me. People could afford them, and so it worked quite well. Now, clients with very like who've been in 7 therapies with a whole list of chronic problems and very complicated. In a case like that, of course, I think I will want to do a longer assessment if the client can afford it. Or if somebody else is helping to pay for it, like insurance or something else. If the client can't, I'll still sometimes just do a brief assessment, knowing I'm giving the person one piece. There'll be lots of unanswered questions, but that they may be able to take that and take their next steps.
Excellent, thank you. We've had a few that came in sort of around this topic. People are wondering if you had any tips or insight on how you handle people who are convinced they have a diagnosis that you don't think they have, or how you manage defensiveness with patients who are convinced of a self-diagnosis.
Yeah, in general, I had that thing about we never argue about a finding or argue with the client. You know, if a client is insisting on something that the MMPI doesn't show, or I'll just say, "Oh, isn't that so curious? Because you see yourself that way, but this test doesn't really show it." So, I mean, I wonder how we can put that together, how that would happen. I don't insist I'm right and get in a power struggle about it, but I don't necessarily back down either. And if I know that's coming up, I have a little trick I'll do. So sometimes I'll say, you know, I want to talk to you about this result. I'm not sure, I'm not actually sure it's right, but I've got this book by Yossi Ben Poref. And let me tell you what he says about this scale. And, you know, sometimes he's wrong. And let's just see what we think about it. So that way I preserve my alliance with the client, but
Mhm.
but I still get the information in. So it's a
Absolutely.
really useful way to use Yossi's book.
Good book to have, absolutely.
Yeah.
Have you ever had an invalid result from an MMPI? And what do you do when you get invalid results?
Oh, sure. I don't work in settings where that happens a lot, but I have had them. I still consider it a communication from the client. And I try to talk to them about that. I say, you know, let's say there's a bunch of FP is high and F is high and L and K are way low. And it looks like the client was trying to, I say, you know, what I see on this test is you're telling me you things are very serious. You're screaming at me how bad it is, and you want to get that message across. Does it feel like you were screaming when you took the MMPI? Or if L and K are high, I might say, you know, it looks like from the test that you really were worried and didn't feel like you could just lay it all out. Does that feel right? And maybe it has something to do with how we set up the assessment, you know. Let's talk again about who's going to get the results, et cetera, et cetera. So, yeah.
Excellent, thank you. And I want to be respectful of everyone's time, so we have come to the end. Like I said, we will be reaching out. Dr. Finn has been kind enough. He said he would answer the questions after the fact. So we'll reach out to you via email that you registered. Is there anything left you wanted to say before we head out?
Well, if has more interest in therapeutic assessment, go to www.therapeuticassessment.com. You can join therapeutic-assessment.com. You can join the TAI. We have a newsletter. We have research articles. We have training. So
Excellent. Thank you so much, and I hope you have a wonderful day.